For joining us for this live workshop where we'll be reviewing the top 3 clinical abstracts that were submitted at the NACFC this year. My name is Dr. Sophie Corriveau. I'm an assistant professor and adult CF physician at McMaster University in Hamilton, Canada. My co-moderator, Dr. Anne Stevenson, is a clinician scientist and adult CF physician at St. Michael's Hospital in Toronto, Canada. Anne and I have invited 3 excellent speakers to discuss their clinical research today. Each speaker will have about 10 minutes, followed by 5 minutes for questions. Since this is a live event, please feel free to ask your questions. Have a look at the right-hand side of your screen. You'll notice that there's a chat tab and a Q&A tab. We encourage you to chat socially in the chat tab, but please post your questions in the Q&A tab to ensure that we see it. So I'll start by introducing Alexander Painter. He's a biostatistician at CFF TDN Coordinating Center based out of Seattle, Washington. Alex will be discussing his research looking at home versus clinic spirometry in measuring lung function.
Thanks, Sophie. So we all know that home spirometry was sort of a curiosity. It was slowly working its way into CF research in 2019, and then all of a sudden in 2020, it became kind of front and center as it was the only way to continue both clinical monitoring and research in many cases. So what we've done today is a retrospective analysis of a study that was conducted at the TDN a few years back. That was the EI study. And we are going to kind of summarize what we can figure out about home spirometry based on that data. I have no disclosures related to this presentation. So I just want to start by kind of delineating the questions that we're hoping to answer today. So the first one is whether or not home spirometry is different or biased compared to clinic spirometry. If it is biased, we want to know if that bias resolves over time. In other words, as people get more experience with their devices, do they improve in their similarity to clinic spirometry? And the final question we want to answer is how similar change-based endpoints are. So in other words, cross-sectional bias is one thing, but change-based endpoints are more frequently the endpoint that we care about in research contexts, and we want to make sure that that's the same as well. Having longitudinal data in the EI study actually allows us to do that. So the EI study was, as I said, conducted from 2011 to 2015, so a few years old. It included a few adolescent participants, about 30% were under 18, 14 to 18 that is, and the rest were adults, a wide range of adult ages. And home spirometry in EIS was not really intended as a replacement for clinic spirometry. The real goal was to use home spirometry to identify pulmonary exacerbations. And the idea was that if you could identify them quickly, you could treat them quickly, and that's not so much what we're interested in today. We're interested in it because it's a rich source of data for us to analyze home spirometry itself. So the features of the EI study that make it a really nice data set for us to look at home spirometry are that we have twice weekly spirometry measures, so pretty frequently, probably more frequently than most people are using it in the clinic currently. And we have longitudinal data, so a full year of follow-up that we can compare clinic and home spirometry side by side. We can look at change over time outcomes, things like that. The last thing that is really important about the EI study is that it's realistic. It's at-home use of spirometry devices. So if you follow the home spirometry literature, a lot of the validation studies are looking at a home spirometer in a clinic setting, which is not really the same thing. So the realism of this study, the fact that it was actually used at home by real patients and really uploaded as if it were in a study, is a big advantage. So this is example data for one participant. And you can see we have the clinic data plotted in pink and the home data plotted in purple. We have many more home observations than clinic observations here. We have home spirometry twice a week, and clinic spirometry is only done once every 3 months as usual. So we have to decide how we're going to pair these up. And there's a variety of strategies you could use, but we're going to be doing sort of the simplest, just looking at the data in kind of its raw form, which is to take the closest home spirometry measurement in time, and we're going to match it up to the clinic spirometry measurement that we're trying to analyze. For any clinic spirometry measurements where we don't have a home measurement nearby, like this third one on the right, we're going to be excluding those from our analyses. So a quick side note, there are other analytic strategies that we did pursue and we did look into. So for instance, you could take an average of all the home spirometry observations within a week or two of the clinic spirometry. You could do a linear regression on both these trajectories and you could analyze it that way. But this analysis procedure is it's the most flexible in that you could apply it to almost any study design. And it's not dependent on the fact that we have this really frequent home spirometry measurement. So we do think it's important to analyze this way to start. If anybody has questions about those, I'm happy to answer that in the Q&A session. We just only have 10 minutes, unfortunately. So the first thing that we're plotting here is just if you take the previous plot, you take that difference and you do it over all visits and in all patients. And what we find is that you have a -2 difference estimate here. And what that means is that home spirometry tends to be about 2 points lower than clinic spirometry on the ppFEV scale. So not only is this negative, but it's statistically significant. So we would say, yes, there is actually a bias in home spirometry as compared to clinic spirometry. So right away, we can say that this would need to be adjusted for, certainly in any study where you had both home and clinic spirometry and you wanted to analyze them together. But it might be important in a lot of study designs to appreciate this. One of the hypotheses for why this bias exists is that people just aren't used to their home devices yet. So maybe if we give them time to get acclimated to their devices, they'll get used to it just like they are to the clinic spirometer, and this bias will resolve. So having longitudinal data allows us to actually analyze this. That's what we do in this next plot. So we break the previous estimate out into 5 separate estimates based on how long they've been in the study. So on the x-axis, we have it labeled by baseline, 3 months, 6 months, 9 months, and 12 months. And if it was experienced with the device, we would expect this bias to very quickly resolve. So certainly by 3 months, it should be pretty much non-existent. And we can see that's not really the case. All of these estimates separately are negative, so it's not kind of bouncing around 0 once they've been in the study for a while. And even at 6 months, we're talking about people that have used their devices for 50 separate days and 3 times a day. So that's a pretty experienced participant with their device. And we don't find a lot of evidence that this bias completely resolves with a kind of a lead-in period to get used to everything. The final analysis we want to share with you today is what happens when you do change over time estimates. So this is plotting the change from baseline in clinic and home separately. So in pink, we have the clinic observations, and in purple, we have the home observations. And we're analyzing these separately. So you can think of this like if we did hypothetically a study that had one or the other. And there's kind of good news and bad news with this plot. The good news is that the clinic and home observations tend to track each other pretty well. So if you look at the 6-month estimate, for instance, it's about a change of 3 points decrease in clinic and home. But the bad news is that the variability is much, much greater in the home devices. So the width of the confidence interval is one way that you could visualize that. And we've also written the standard deviation of the change in the x-axis. So the big problem with the variability is that it's the way that we determine whether a study is adequately powered. So if you have twice as large a confidence interval and you think about trying to power a study, you would need 4 times as many participants to get those confidence intervals to shrink down. So just to very briefly summarize what we've shown so far, home spirometry tends to be lower than clinic spirometry. It certainly needs to be adjusted for in any study that uses both, and probably in many studies that use one or the other. The bias didn't significantly improve over time. So if, this is important for people that are considering doing a lead-in time to resolve this problem. Change from baseline estimates tend to be similar, but the variability and change over time is considerably higher in home devices. And it's a big enough difference that it could really have a big impact on study design. So future directions for research, we have a couple things here that actually could really help some of the pitfalls that we've noted here. Virtual coaching is one aspect which could sort of mimic the motivational component that you get by having clinic spirometry taken. Modern equipment can always help. The study started collecting data in 2011. The devices were available even before that. So we're talking, laptops, dial-up internet connections were a part of the considerations when they were designing this. And modernization of equipment would at least make it easier to use and make it easier for patients to adhere. And kind of prospective monitoring, and by that we just mean designing a study from the ground up and knowing that you're going to use home spirometry as an outcome changes the way that you monitor that data as it's coming in. And the last thing doesn't help us, but it's something that we'll have to contend with eventually, which is the existence of multiple spirometers where these cross-sectional and longitudinal parameters could be different in different spirometers. And we'll probably eventually have to contend with that in CF research. Just want to end by thanking all the original participants of the EI study and the staff at the TDN sites who, of course, worked for years to collect this data. It's the only way that retrospective analyses like this are possible. And I'll wrap up there and take any questions.
Thank you, Alex. I'm just waiting for some questions. I'll start actually with a question of my own while I'm waiting for other ones to come through. So it's interesting that home spirometry tends to be lower than clinic spirometry. Given your results, what role do you think home spirometry has moving forward? And do you think these data should be captured in CF registry data?
Yeah, I think certainly collecting in the registry helps us study it further. And I would describe home spirometry's role in CF research as basically essential, right? Because we still are all living through a pandemic where we're all having a virtual meeting right now because we can't meet in person. And it's the same thing for CF research. We have a lot of restrictions on aerosolizing procedures. And I think that we sort of need to accept that home spirometry is going to be a part of the discussion and do our best to analyze it in a way that allows us to pair that with previous results that we've published. So I feel like I'm forgetting part of your question, Sophie. Did I forget anything there?
No, that was, I guess, should we be capturing this data in CF registry?
Yeah, I think, yeah, certainly capturing the registry could help us learn more about it and help us figure out. I think this particular result that home spirometry tends to be lower than clinic spirometry has been replicated a few times in a few studies, but having a huge data source like the registry seems like a fantastic way to continue to generate research on that subject. And certainly long-term outcomes, 5 years, things like that will be probably much easier to capture in the registry than in a funded study.
And do you think results would differ at all depending on the device being used?
Yes, I think they would. The question is whether it's significantly different, and I think that there's not always a ton of published research about the devices that come out. So I'd be excited to analyze this if we have the opportunity to compare devices, but it's a bit hard if you use one device in one study and one device in another study. The ideal setting is to randomize people to a device or something like that. And as far as I know, nobody's done that, but we'll be excited to continue looking into that at the TDN, I think.
And I see a question coming from the audience. So for patients that might be interested in pursuing home spirometry, do you have any idea what the range of cost would be?
Oh, unfortunately, I'm probably the wrong person to ask about that. I know that devices vary a lot in the cost. I know I think Mir makes some devices that are as low as $100, and there are certainly some that are, 500 or 1,000. But actually, it would be great if one of the clinicians had a better idea than me. Unfortunately, I'm the wrong person for that question.
No problem. Thank you again.
Thank you.
Okay, so I'm going to go along and introduce our second speaker. So Dr. Brent Birmingham, he's a physician at the Medical University of South Carolina. Dr. Birmingham will be discussing his work looking at elexacaftor, tezacaftor, and ivacaftor treatment in advanced lung disease.
Well, thank you for the introduction and the opportunity to speak today. So my name is Brent Birmingham, and I am a second-year pulmonary and critical care fellow at the Medical University of South Carolina. And today I'd like to present our work regarding the clinical efficacy of elexacaftor, tezacaftor, and ivacaftor in patients with advanced lung disease and cystic fibrosis. And I have no financial disclosures related to this procedure. And today we're going to be discussing the effects of CFTR modulators in advanced lung disease. And for the purpose of this talk, we defined advanced lung disease as an FEV1 less than 40% predicted or the presence of high-risk features. And I'd like to begin with the summary of what's known about modulators in patients with advanced lung disease. So in patients with the G551D mutation started on ivacaftor, there was a mean increase in FEV1 of 5.5% with peak spirometry that occurred at day 100. This was an unexpected because prior studies with modulators showed a mean or a peak benefit around week 2, which suggests that there may be some unique features in advanced lung disease that affects the trajectory of their lung function with response to modulators. Later combinations with lumacaftor and ivacaftor showed a more modest improvement in lung function, although in a greater variety of patients, but did demonstrate an increased rate of respiratory adverse events at initiation that was dose dependent. And then some additional data from the tezacaftor and ivacaftor phase 3 studies, some subgroup analyses showed improvements in lung function in patients with advanced lung disease. With this improvement, it's currently unclear how CFTR modulators should affect lung transplant referral timing. I'd like to highlight now an important figure from the 2019 CF lung transplant guidelines regarding the progression of CF lung disease. And as lung function decreases to below 50% predicted, lung transplant should be discussed on an annual basis with barriers to transplant identified and addressed, for example, poorly controlled diabetes, substance abuse, or a poor social support system. As lung function continues to decline, patients should be screened for markers of disease severity, including hypoxia, hypercapnia, pulmonary hypertension, low weight, pneumothorax, massive hemoptysis, or colonization with high-risk organisms. If present or if FEV1 decreases to below 30%, patients should be referred to a transplant center for evaluation. Our center and the other centers participating in this study participated in the CF Foundation Lung Transplant Research Dissemination Network QI initiative and utilized these guidelines during our preclinic meetings to improve consistency in our approach to patient care across providers. So the rationale for our study was that despite patients with advanced lung disease being excluded from phase 3 trials, patients with advanced lung disease are receiving therapy with unknown clinical efficacy and safety profile. If effective, treatment with triple combination therapy could alter the need and timing for lung transplantation referral. So with that in mind, our objective was to characterize the short-term clinical efficacy, safety, and implications for transplant referral of triple combination therapy in patients receiving triple combination therapy with elexacaftor, tezacaftor, and ivacaftor with pre-existing advanced lung disease. We performed a multi-center retrospective open-label cohort study in 3 centers in the southeastern US participating in the CF Foundation Regional Dissemination Network QI initiative. And patients were collected from local registries based off of an FEV1 less than 40% predicted and high-risk features. Patients were started on therapy following FDA approval, and patients who were not genetically eligible were identified as controls for comparison. Baseline FEV1 was defined as the most recent spirometry prior to initiation of therapy and outside of an acute exacerbation, with follow-up spirometry obtained between 2 and 12 weeks from initiation. For the control group, baseline FEV1 was defined as the most recent spirometry prior to FDA approval, and follow-up was obtained within 12 weeks of that time. In total, we identified 60 patients with advanced lung disease on triple combination therapy started during that time period, and an additional 10 patients who were not genetically eligible for comparison. There were similar demographics with regards to age, BMI, gender, colonization with Pseudomonas, and pooled high-risk features. Expected differences in genotype, as well as a small but significant difference in the incidence of pancreatic insufficiency were noted. And in response to therapy, we saw a mean improvement in FEV1 of 7.8% with triple combination therapy from 31 to 39% predicted, which was statistically significant. Among the control group, there was no improvement in lung function over that same time period. And here is another depiction of the change in lung function measured during that 2 to 12 week period, with improvement noted in the treatment cohort and no improvement noted in the controls. And here's another depiction of this change, and we're plotting FEV1 pre-triple combination and post. And here what I'd like to point out is the positive slope of this line, which suggests that patients with higher baseline lung function experience more improvement with triple combination. Based on the guidelines we visited earlier, 40 out of the 60 patients in the treatment arm met indication for transplant referral at the time they were started on drug, and about half the patients in the control arm. In response to therapy, the number of patients who had an indication for transplant referral decreased by 20, with more of those patients now meeting indication for transplant discussion, but not referral to a transplant center. And 7 patients actually improved to the point where they no longer had an indication for transplant discussion at all. And no such improvement was noted among the control patients. And in fact, one of them had a slight decline in their FEV1 to the point that they met an indication for transplant evaluation. Among the patients for whom referral was indicated, we sought to measure the response in FVC, since this can affect the lung allocation score. And here we see among patients who had a referral indication, there's a 10% improvement in FVC, which would have the effect of moving them lower down the transplant list should they become activated. And this improvement in lung function means little if the drug can't be tolerated. And fortunately, adverse events among patients started on treatment were rare, and there was one severe event, a patient who had distal intestinal obstruction syndrome and pancreatitis simultaneously. Only one patient among the 60 had treatment discontinued during the time period, and this was following a lung transplant and was not directly related to treatment toxicity. So in summary, treatment with elexacaftor, tezacaftor, and ivacaftor among patients with advanced lung disease resulted in a mean improvement in FEV1 of 7.8%. And our study had a large number of patients taken from multiple centers, which suggests generalizability and real-world experience. Triple combination therapy was well tolerated, and there were fewer guideline-based indications for transplant discussion and referral following treatment. In the future, we'd like to measure longer-term spirometry, both to make sure that this effect is durable and to make sure that there's not a second peak, just like in the G551D study that had been reported previously. We'd also like to measure additional safety data. Due to the short-term nature of this study, it's fairly limited at this point. And then eventual registry analysis to help see whether we're affecting disease trajectory and eventual need for lung transplantation among patients with cystic fibrosis. And I'd like to acknowledge the CF Foundation Lung Transplant RDNQI initiative and the local representatives at MUSC, my mentors, Brian Garcia and Patrick Flume, and at UAB, the team led by Marty Solomon and Leah Cohen and her team at UT Southwest. And with that, I'd like to open to questions and discussion.
Thank you, Brent. I do have one question. I noticed in your homozygous patient group, where you noticed that the change in lung function, like you mentioned, wasn't as significant as was seen in the studies. How many of those patients had been on CFTR modulators, like other than the triple combination prior to being in the study?
So I don't have all of that data for all of our sites. I know the patients locally here at MUSC, I believe all of them were on dual combination therapy prior to triple combination if they were genetically eligible.
Okay. Thank you. And you mentioned some adverse events that was seen. I'm just curious what your approach is, or if you've come across any patients who have any such adverse effects, such as the elevation in liver enzymes, what your approach has been with the triple combination therapy.
I think a lot of that depends with any adverse event on the severity of it. And most of the ones we've seen locally have been very mild elevations in transaminases that we've just watched and continued treatment. I don't believe we've stopped treatment on any patients due to laboratory abnormalities or anything along those lines.
Now there's a question here. So the The numbers may be too small for subgroup analysis, but did you look at any subgroups such as sex, genotype, microbiology?
We've started to look at that, and I know we've pulled out thus far gender, and both groups did have significant improvements in lung function. And when comparing the change between the two groups, there was no significant difference between those. Some of the other ones we're still working through at this time.
Okay. In your experience, if patients do not respond to triple combination with respect to their lung function, have you seen other improvements in terms of quality of life?
Anecdotally, I have seen a few patients who did not have significant improvement in spirometry, but did feel symptomatically better. We unfortunately don't have pooled quality of life improvement scores pre and post treatment. So I can only provide anecdotally what I've seen, but I have seen that.
And do you have any data about weight change after triple combination in advanced lung disease?
That's something we're currently investigating. So due to the short-term nature of this study, some of the patients, the pre and post data was as little as 2 weeks apart, which is likely not enough time to significantly affect their BMI. But in some of our longer-term work that we're looking towards, that's something we're going to include in the eventual analysis of that.
And I'm not sure if you guys had analyzed this or it's the same sort of same idea, but one of the questions is, did you see improvements in dyspnea, exercise tolerance, or number of exacerbations?
We have anecdotally seen improvements in dyspnea, but again, we don't have MMRCs or anything like that to quantify that improvement. And I think the limited time data that we captured here is probably insufficient to measure real exacerbation frequency. But I think that along with weight is going to be something we continue to monitor.
Okay, great. And I think all the questions have been addressed. I'm just looking here. Yeah, okay. Thanks again, Brent. So
Thank
our
you.
last so our last speaker today will be Dr. Jonathan Kogan. Dr. Kogan is an assistant professor in the Division of Pulmonary and Sleep Medicine at Seattle Children's Hospital and the University of Washington. Dr. Kogan will be presenting his work on the optimal therapy for inpatient treatment of pulmonary exacerbations.
Awesome. Well, thank you very much for the opportunity to present our work. My interests relate to how we use antibiotics in people with CF, and specifically when it comes to antimicrobial stewardship. So this study was looking at how we use anti-pseudomonal antibiotics specifically. The only disclosures I have are that I have some CF Foundation funding to do this work and others. So I think most of us know that pulmonary exacerbations are associated with significant morbidity in people with CF, and that in general, treatment includes increasing airway clearance and also the initiation of antibiotics, whether it's oral antibiotics or IV. I think most people also know that the standard approach in people with CF and Pseudomonas aeruginosa infection, when you're trying to treat for IV specific exacerbations, is to use 2 IV anti-pseudomonal antibiotics, even though there's limited evidence to support this. The idea is that perhaps it can reduce some antimicrobial resistance, though there's limited data to suggest that. And in fact, in 2009, the CF Foundation put out some pulmonary exacerbation guidelines, and those specific guidelines note insufficient evidence to recommend a double antibiotic coverage strategy over a single antibiotic strategy, though it's still standard of care at this point in time. So we were interested in trying to address this question, if possible, using observational data. So our study aims were specifically among people with chronic Pseudomonas infection to determine if the use of 2 IV anti-pseudomonal antibiotics would be associated with improved clinical outcomes when you compare that to 1 IV anti-pseudomonal antibiotic, either with or without the addition of an inhaled antibiotic. We chose 3 clinical outcomes. The first is the pre to post pulmonary exacerbation change in lung function. Our second 2 outcomes were ones that are generally used in most observational studies, I feel like, for pulmonary exacerbations, looking at recovery to baseline lung function, or specifically greater than or equal to 90%, and then time to the next pulmonary exacerbation requiring IV antibiotics. So this was a retrospective cohort study. It utilized the CF Foundation patient registry and the Pediatric Health Information System dataset. These two data sets were linked in collaboration with myself and members of the CF Foundation and Children's Hospital Association a couple of years ago. The CF Foundation, as all of us know, is really that the CF Foundation registry is a treasure trove that provides data on clinical and demographic information on a whole host of people with CF. And FIS, on the other hand, is an administrative data set that includes information on anything that's billed for during a hospitalization. So for this study, it was very useful because we were able to determine how many antibiotics and what specific antibiotic a given individual received for their pulmonary exacerbation treatment. People with CF were included if they were hospitalized between 2007 and 2018, and then 6 to 21 years of age at time of hospital discharge. We defined chronic Pseudomonas as having a PA-positive respiratory culture in at least 2 age quarters over a 2-year period. So we tried to come up with a fairly rigorous Pseudomonas definition. We also are really concerned about how to classify our exposure, since antibiotics are frequently switched, added, or subtracted during a hospitalization. So we defined our exposure as treatment in at least 80% of hospital days. So for example, in order to be included in a 2 IV antibiotic group, someone must have been prescribed the 2 IVs in at least 80% of all hospital days. So we're really worried about indication bias, namely that people who would be receiving 1 IV anti-Pseudomonal would be or at least different in some way compared to that standard of care of 2 IV antibiotics. And so in order to try around this, we used propensity scores and more specifically inverse probability of treatment weighting. Essentially what this does is it takes a set of covariates, and for the purpose of this study, it's the covariates listed here, and comes up with a probability that somebody will receive either 1 IV or 2 IV antibiotics. And in a way, it's trying to mimic a randomized trial to a certain extent, with, of course, the inability to adjust for unknown confounders that are listed. So this is our flow diagram illustrating the cohort selection. We were able to successfully link over 10,000 children and adolescents with CF through the CF registry linkage after removing people who were less than 6 or greater than 21 years or did not have an eligible pulmonary exacerbation. We got our cohort down to about 8,700 or so. And then we had several other exclusion criteria. We did require a drop in baseline lung function of at least 3%. If people were not hospitalized between 2007 and 2018, they were, of course, excluded. If there was a length of stay that we deemed to be too short or too long, and then other various exclusion criteria. This got our cohort down to 3,294 eligible children and adolescents who contributed over 10,000 pulmonary exacerbations. The next step at this point was to then determine among these pulmonary exacerbations, which ones would be deemed as those having chronic Pseudomonas infection. And so of these 10,000, about a third or so were from people who had chronic Pseudomonas infection. So for the purpose of this study, the overall pulmonary exacerbation cohort was 3,428 exacerbations. This is a figure really just showing the impressive variability in how people use anti-Pseudomonal antibiotics in people with CF. So on the y-axis, you can see the proportion of exacerbations per each of these antibiotic categories. On the x-axis, you can see all 45 FIS participating hospitals. On the top of each column is the number of exacerbations that came from each of the FIS hospitals. And then each color relates to one of the 4 exposure groups. So the purple is all exacerbations treated with 2 IV antibiotics and 1 inhaled antibiotic. The blue, which is by far and away the most common, as you see here, is the 2 IVs with no inhaled antibiotic. The green is treatment with 1 IV and 1 inhaled. And then the salmon color is 1 IV and no inhaled. I think the take-home point from this is really lots of variation sort of all over the map here. Not very surprising, but nonetheless interesting. This is our table 1 showing some pulmonary exacerbation level characteristics of the cohort by antibiotic combination. I think some take-home points here. The first one is that by far and away the most common antibiotic exposure group was the 2 IV no inhaled antibiotic group, followed again by the 2 IV 1 inhaled antibiotic group. But we did have over 450 exacerbations in this data set that utilized just 1 IV antibiotic. Other take-home points that I tried to bold on the slide are that people who receive 1 IV antibiotic do tend to be a little bit sicker than those who received 2 IVs, which was not overly surprising to us. As you can see here, their baseline lung function was slightly lower. They also had more pulmonary exacerbations in the prior 12 months. And also more of these exacerbations were treated with a non-anti-pseudomonal antibiotic, suggesting treatment for a concomitant pathogen like MRSA as an example. So getting to the results, this is looking at the pre to post pulmonary exacerbation change in lung function. So the reference group here is 2 IVs with no inhaled antibiotics. And as you can see here, there essentially is no difference in the pre to post pulmonary exacerbation change in lung function between the reference range and any of the 3 additional exposures. And then similarly, when you look at return to baseline lung function, you can again see that there is no increased odds of returning to lung function baseline among people treated with 2 IV anti-pseudomonals compared to people treated with 1 IV anti-pseudomonal with or without an addition of an inhaled antibiotic. There was, however, something to see here with the time to next pulmonary exacerbation requiring IV antibiotics. So compared to those who were treated with 2 IVs but no inhaleds, there was a 31% increased hazard of a future pulmonary exacerbation requiring IVs in the group that received 1 IV and 1 inhaled antibiotic. What is kind of interesting, though, is when you look at the 1 IV no inhaled group, there was no difference there. So this could be related to some residual indication bias, but I'm obviously not sure. We feel like some strengths of the study were the large number of exacerbations available for analysis coming from a lot of US children's hospitals that was fairly generalizable. We also were pretty happy with our chronic students infection definition in an attempt to avoid misclassification. Of course, this study has many limitations. The first and by far the most important one is still an inability to completely adjust for indication bias, and that's just inherent to all observational studies. We did exclude people who had lung function drops of less than 3%. And the reason for this was we felt like we wanted to have some sort of signal and have a minimal drop since 2 of our 3 outcomes were related to lung function to begin with. We also excluded home IV antibiotic treatment due to limitations of the data sets, and we're unable to include adults since we use the FIS data set for our inpatient data. So in summary, compared to treatment with 2 IV anti-pseudomonals, the use of 1 IV anti-pseudomonal antibiotic with or without 1 inhaled antibiotic was not associated with improvement in any of the lung function outcomes. But among pulmonary exacerbations treated with 1 IV and 1 inhaled, there was a 31% increased hazard for future exacerbation requiring IV antibiotics compared to treatment with 2 IV anti-pseudomonals. Future studies are clearly needed. This is not a study you can hang your hat on, but I think it's an intriguing study with intriguing results. And I think maybe brings up the question of whether we really need to expose our patients to all these extra antibiotics when perhaps they're not actually leading to improved outcomes. Lots of people to thank, CF Foundation leadership who helps with the linkage, as well as the Children's Hospital Association. Special thanks to Anna Fano and Franklin Onkiri, the great Seattle children's biostatisticians who really did all this work, my mentors, as well as funding. Hope everybody stays safe during the pandemic. Happy to take any questions. Thank you.
Thank you, Jonathan. While we wait for some questions to come in, I had a question. Has this changed practice at all at your center? And if so, are there any situations where you are still using 2 IV antibiotics?
Yeah, so as much as I try to push all of my colleagues here in Seattle, there's the standard of care still remains 2 IV anti-pseudomonals. So the only times we've really been not using that are in kids who have a much higher risk for acute kidney injury or have chronic kidney disease to begin with, and we're probably avoiding aminoglycosides, or at least IV aminoglycosides. So we're treating with 1 IV beta-lactam and then using inhaled tobramycin as a sort of inside-out therapy. And I will say we did another study looking at inhaled anti-pseudomonals and found over, it was 2007 to 2017, and over 80% of all exacerbations, this is across the country, have used 2 IVs. So it's still very common, I think, throughout the country here, and certainly at our institution as well.
One hypothesis for using 2 IV antibiotics is to decrease selection for resistance. Is there any intent to look at this?
Yeah, so that's a great question. And I thought a lot about this. We were trying to think about what other things we could look at in the study. And the challenge with that question is it's sort of like a chicken and an egg kind of thing. You treat differently people who have multi-drug resistant Pseudomonas. We know that. I think it's undeniable that multi-drug resistant Pseudomonas comes from giving people antibiotics. the nature of this study, since we included all pulmonary exacerbations over a long period of time, would not allow us to really look at that question. You could try to answer it differently, I suppose, by picking a 2 or 3 year period, I guess, of exposure and then following an outcome. And then the outcome would be time to MDR Pseudomonas. I think that would be a really challenging study to do, but certainly an interesting study that we can definitely consider in the future.
And now that we have some data from the STOP-2 trial about duration of antibiotics in adults, do you anticipate a prospective randomized trial comparing single versus double pseudomonal coverage?
Boy, do I hope there is one. I mean, my interests in general relate to how we use antibiotics, and my personal view is we give people too many. I think that would be a really interesting study. There's lots of other studies to look at. Broad versus narrow antibiotic approaches is another one that comes to mind. I just wonder when it comes to, a list of things that are most important to the CF community, and specifically people with CF and their families, if that would rise to the top. I think it's a really interesting study that really should be considered. I don't know if these data are enough to provide equipoise, but as I mentioned at the beginning, the CF guidelines from 2009 on pulmonary exacerbations note insufficient evidence. So there's never been a study really looking into this. So I'd love to be a part of that study if people are interested.
What do you make of the increased hazard ratio for recurrence in the group with the 1 inhaled and 1 IV antibiotics? Are there clinical factors in that group that suggest that this patient group may be at higher risk of recurrence?
Yeah, so that's a good question. And we still haven't really spent too much time thinking about the cause of that. I think, in general, when you see studies like this, my initial impression is we're just missing some confounding that we can't get a hold of since we're using an observational study design. So I think we came into the study a priori thinking that people who would receive 1 IV with or without an inhaled antibiotic would be sicker in some way. And certainly, I showed you guys part of table 1. There's several other variables that certainly seem to suggest that people are sicker in the 1 IV groups. So my initial thought is that that's related to maybe some unknown residual confounding that we couldn't adjust for, or it's real, right? And then maybe 2 IVs actually are helpful. So it's one of those two conclusions, I guess. I'm just not sure which. If I had to guess, I would say we're missing residual confounding since the other clinical outcomes really did not seem to make much of a difference.
Okay. And in the 2 IV cohort, was there a regimen that was present in the majority? An example, tobramycin and cephalosporin.
So I'm really proud of myself because I made some bonus slides. So here you go, you guys. Let's see if I can get to it. So this is, I think, trying to answer that question a little bit. So another thing we're actually doing with the study that we haven't done yet is actually compare broad versus narrow antibiotic approaches and looking at the same outcomes. So this is a breakdown of the more common of the 2 IV antibiotic approaches. So I guess to answer that question, the most common one was definitely ceftazidime and tobramycin, followed, as you can see here, by Miro, Tobra, and cefepime, Tobra.
Okay, great. And we have time for one more question. So use of a single IV without inhaled antibiotics may signal a healthier patient versus single IV plus inhaled. Maybe that signals a history of acute kidney injury and greater history of antimicrobial burden, which may account for difference in outcomes seen. So I guess it's more of a comment whether that was the reason that you saw that increased hazard ratio.
Yeah, maybe. It's a good question on whether the 1 IV alone without an inhaled antibiotic, if those people were, I guess, healthier perhaps than the 1 IV, 1 inhaled. I think looking at the table 1 data, it seemed to me that the 1 IV group, irrespective of whether they also received an inhaled antibiotic, were still sicker based on lung function and several other variables compared to those who received 2 IVs. But it's certainly possible. In general, it wouldn't surprise me that the 1 IV treatment is due to some history of toxicity, as being mentioned in the question, either related to the antibiotic itself or to just the kidney disease secondary to the antibiotic, or hearing loss, ototoxicity, that kind of stuff.
Okay, great. Well, this concludes our workshop, and I want to thank our speakers today. And those of you who've tuned in, I hope you enjoy the rest of your conference.